Hi, I'm Steve Weiss, and I'd like to welcome you to this edition of You and Your Health. Today we have an old friend coming back to us, Dr. David Paulson, formerly the Chief of Urology at Duke. In the past, we've talked about men's diseases, prostate cancer, benign prostatic enlargement. Today, however, we're going to shift to what concerns many women here in Bowel Niles, and that's urinary incontinence. Welcome, Dr. Paulson.
Good to be here again.
Hi. Before we get started specifically, would you like to tell us a little bit about the anatomy of the female pelvis and how you would define incontinence?
Well, women basically are troubled with two types of incontinence. One is stress incontinence, and that's the incontinence that occurs when you laugh or you jump up and down on the tennis courts or you strain. And then there's urge incontinence, and urge incontinence is when you just have to go and you just can't get to a bathroom in time. And they're caused by two totally different processes.
Now, which is the most common?
The most common is probably the stress incontinence. It's basically an anatomic difficulty that the women have in the way that they were put together over thousands and thousands of years.
And what is that?
Well, the bladder, for both men and women, rests on a muscular floor that basically holds all the organs in the pelvis and in the rest of the body. That muscle, transverse muscle, which runs across the pelvis in females has several holes in it. One is for the birth canal, and the other one is for the urethra. Men don't have the birth canal going through, so they have a much stronger floor to support the bladder. Women have their bladder which rests right on this muscular floor, and then they've got a very, very short urethra, usually measuring no more than 3 or 4 centimeters in length. If you imagine the bladder to be say a ball of yarn that's hollow, and all the outside fibers on the ball of yarn represent muscle fibers, those fibers are all entwined, and then at the bottom of the bladder they form a tube which is similar to what you call one of those Chinese finger traps. The muscles all fall around this tube. When women have nice pelvic floor support, that tube is long, and if you remember from a Chinese finger trap, when you pull it long, you can't get your fingers out. But when that finger trap shortens, the diameter of the finger trap opens up and you can get your fingers out. And that's basically the problem that women have.
Now, is this problem related to specific things in a woman's life? We talked about the birth canal.
It's related to several things. First, women that have multiple births stretch the fibers of the muscular diaphragm so that everything sort of falls down further in the pelvis. And as the bladder falls down further in the pelvis, that finger trap becomes shorter and shorter, and so it opens up more and more. And when women go to have a procedure that will reintroduce continence again for stress incontinence, they basically lengthen that tube and pull the bladder up into the pelvis so that that finger trap becomes much narrower, the tube becomes much narrower. And interestingly enough, the inner walls of that tube are moist like the inside of your mouth, and when two moist surfaces come together anatomically, they tend to sort of stick together. But when they're open, they don't, and then when the woman happens to hit a high note when she's yelling or singing or hit a great shot, that urethra opens up and they leak.
So
and
they
that's a
shouldn't
problem.
be doing a lot of laughing at weddings and things like that.
Well, no, you want them very happy all the time.
But so we can carry this forward then. Other problems, obese women would have this.
Obese women have this. Women that carry a lot of weight in their lower abdomen will have this. Women that have had multiple births may have this. And unfortunately, it's just the wear and tear and the weakening of that pelvic diaphragm, which lets everything fall further and further down into the pelvis.
Now, is this hormonally related too? Because we see a lot of people who are postmenopausal who may not have had children who will develop stress
It
incontinence.
is related to loss of hormonal support. The hormones, as women lose estrogens, the cells that line the urethra become flatter, and consequently, when the walls of the urethra are opposed, they don't have the succulence and support to close nicely. And women lose a little bit of the muscular support in the pelvis as they lose their estrogens fall off with advancing age.
Now, when would you think treatment is necessary? Would this be a subjective thing or an objective?
Women usually seek treatment at that point in time that the incontinence begins to bother them socially or even personally, depending upon how fastidious they are.
And how would you evaluate them beforehand to know if a procedure or a medication or so on might be worthwhile?
Most women should consult a urologist or a gynecologist, and the classic examination is to have a woman fill the woman's bladder up and have them lie down in stirrups, and all women know what that is. That's part of the gynecologic exam, and they cough. And if they cough and a stream of urine comes out, you know that you have not got adequate pelvic support, and then you are a candidate to have a procedure which will, again, pull the bladder back up into the pelvis, lengthen the urethra, and allow apposition of the urethral walls and urinary control.
Now, before we talk about surgery, are there anything you should try beforehand?
There are exercises called Kegel exercises, and those are exercises which women can practice. They tighten that pelvic floor muscle up, and that does aid in some women. It doesn't aid in some.
Now I'm going to ask you, as one urologist to another, what do you really feel about Kegel exercises?
I really don't think they're very good.
Okay, because I've never really had
I don't, but
great luck.
everybody says you should use them to start with to see whether or not they work, and it makes psychologically then undergoing surgery after you've tried some benign procedure or exercise, then it's much easier to accept a surgical procedure.
Would you say the same with biofeedback and electrical stimulation and all those other entities? Do you have any success rate at all?
Some of the spinal cord stimulation does work, but I think that's too excessive. Actually, an old thing which used to be done is just to put a pessary in the uterus, in the canal, the opening of the uterus, and just help push the push the uterus further up into the pelvis. It's uncomfortable, but it is an alternative.
And a lot of this goes along with gynecological problems, with prolapse of the uterus and so on.
Correct.
Now, let's just change direction for a second.
All right.
And talk a little bit about urgency incontinence. If you'd like to just sum that up, what we see most commonly with that.
Well, urge incontinence, and I think even men will have urge incontinence, and actually, to some extent, it occurs because as we age, we get less blood flow to the pelvis and into the bladder, and the bladder becomes less pliable. And so it takes less filling of the bladder to all of a sudden make you feel like you have just got to go right that very moment or you're going to have an accident, and sometimes you do. To some extent, it can be psychological. There are women, as soon as they slam their car door or they get to the front door of their house to open the door, they have got to go right away. Some of that, with behavioral testing and behavioral therapy, you can get by. But a lot of the urge incontinence is actually caused by loss of distensibility.
Now, we see all these ads on television for, quote, overactive bladder. Would you like to comment on that in this frame of reference?
Some of those therapies are quite good, and actually Botox does have a place in the treatment of overactive bladder. But before you go and ask your urologist or see a urologist and ask for a Botox injection, you might want to make sure that the person that you're seeing has a fair amount of experience in managing women that have urge incontinence, and that they study you appropriately before they give you the Botox injection.
And how about these other medications?
Some of them are reasonable, and I think they're worth it. They're worth the effort to try them.
Is there a major overlap between the two? Does that become part of the diagnostic workup?
Women can lose pelvic support and have urge incontinence at the same time. But from a treatment standpoint, you'd like to segregate out which is the dominant cause of the loss of urinary control.
And are there any long-term complications to the procedures, or are the established procedures really effective in the long run?
If you're planning on having a surgical procedure to pull the bladder back up into the pelvis and to lengthen the urethra, I would make certain that your urologist or your gynecologist does this frequently and not just occasionally, because the infrequent surgeon, no matter what he does not do his surgery as well as the surgeon who does the procedure with great frequency.
Well, I think that's the case in all surgical
It's
procedures.
true. That is true.
And I'm glad to be at this end, and I'm sure you are too,
I am
not doing
too.
any more surgical
That's right.
procedures. Well, thank you very much. I think this has been very informative, and I think our ladies out there will have learned a lot.
Well, thank you for asking me. It's been a
Thanks
pleasure.
again.
Take care.